We're here today with Dr. Alex Mitchell to discuss an important topic. Does exercise help with depression? Now there have been some contradictory pieces of research recently, and many people have strong opinions. So let me start by asking, what actually is the recommended amount of exercise?
There have been some new guidelines on this in the UK, and the recommended amount in minutes is 150. So that's 30 minutes, 5 times a week. And in addition to that, for young people, the recommended amount is 1 hour per day, just 1 hour per day. So for people 5 to 18, 1 hour per day is the recommended amount, otherwise 150 minutes. And that's the minimum, and it's expected that you undertake moderate to intense exercise during that period. Now that's difficult to define, but in broad terms, it's feeling out of breath, noticing your heart rate is racing and working up a sweat. So that would be just an everyday definition of moderate to intense.
Right, okay. But are the population actually achieving this?
Well, exactly, that's the key question. Are they achieving it? Well, the answer generally is no. In fact, there's a whole series of interesting papers that came out last year in the Lancet. And Lancet looked at this question from a global perspective, so which countries were achieving and which countries weren't. Essentially, from a global perspective, 31% of people around the world actually fail to achieve that target. So 70% do achieve it. But in the Western world, we're worse. Perhaps no surprise there. So in the UK, roughly 2/3 don't achieve that target and 1/3 do achieve it. But that's by self-report. That's if you allow people to say, do you think you're achieving that minimum 150 minutes a week? If you actually measure people's participation in exercise, it's actually much less. So for example, Health Survey England 2008 actually measured, I think it was 5,000 people using pedometer or accelerometer that you wear during the day. And only 5% of people, when measured, actually achieved the minimum recommended amount. So it's actually slightly unclear what percentage is not achieving it, but we know it's the majority in the Western world who are not achieving the minimum recommended amount of exercise. And of course, in mental health, the proportion who are not achieving it is higher. We don't have fantastic figures on that, but in the studies that I'll refer to later, if you look at their baseline rates, then about 10% of people by self-report with depression are achieving the minimum amount of exercise.
So how many minutes of exercise do people actually typically achieve?
Okay, so if you look at a typical day and break it down into what they're doing in the day, it's a kind of depressingly low figure. The rate in the Western world, in the UK, USA, is roughly 8 to 12 minutes of exercise a day on average across the population. So they're roughly across the population achieving 60 minutes a week. However, that's because there's certain outliers, quite fit, healthy people in the population who are bumping that figure up, and a large tail of people who are not really exercising at all. If you look at activities in the day, it's actually quite interesting because, things are changing in the population. But when you ask by self-report, what do people do in the day? 4 to 5 hours of the day is spent at the desk. 2.5 hours a day typically is spent watching TV, and 2.5 hours is spent at the computer at home. And if you look at screen time, we used to look at TV time, how much time are kids or adults spending watching TV a day. But with the advent of mobile phones and the internet, it's more applicable to look at screen time. So Nielsen, the survey company, looked at the screen time in the USA. And they found that in the late 2000s onwards, then the average amount of screen time per day was 8.5 hours for an adult, which is really shocking when you think about it.
So when we talk about exercise, what do we actually mean?
Well, we mean doing a physical activity that is exertional, generally aerobic, and causing some increase in heart rate, sweating, being out of breath. So in everyday terms, it's exerting yourself. And exercise can be measured by intensity and duration. Intensity is a little bit hard to quantify, but in the literature they look at METs, which is energy consumption in like O2, oxygen consumption, per kilogram per minute. And at rest, they just say at rest the average MET would be, let's define it as 1. And then we'll multiply that up for more intense exercise. So for example, going for a brisk walk more than 4 miles an hour would be 3 METs, 3 times the equivalent of being at rest. And going jogging or cycling to a moderate degree would be 6 plus or 6, 7 METs. And that zone of 3 to 6 is considered moderate exercise, and 7 plus quite intense exercise.
So, you talked about the MET, and is that how exercise is measured in most studies?
Well, no. Most studies just ask for self-disclosure, self-report. But some studies use the pedometer or accelerometer method. And some studies may look at observation, and some very advanced studies may actually measure energy expenditure, but that's very unusual. It's not really been done in mental health to actually measure energy expenditure very accurately, but just in terms of behaviour, yes, that has been looked at. How many minutes are people engaging in?
Right. So if we actually now think about depression, is exercise a recommended strategy for combating depression?
Yes, it's currently recommended in the US guidelines, in the UK NICE guidelines. NICE guidelines were revised for depression 2009. There are some more recent guidelines on that as well. More recent guidelines basically do advocate exercise for depression. But one of the problems is the more recent studies have not always been consistent with the older studies. If you look for the evidence, one way to look at the evidence is to look for authoritative reviews of previous primary data studies, and a good source for that is the Cochrane Review Network, and Cochrane review a wide variety of topics, and they've just updated their exercise and depression review 2012 actually. So they looked at 30 studies relating whether participation in exercise helps depression. The vast majority of those studies are comparing exercise against a waiting list or placebo or effectively no active treatment. And if you look at those studies, the comparison of exercise versus effectively no treatment, then there is a definite effect on current depression of participation in exercise.
So that's what the latest studies show. The latest show actually that there is a definite effect, because I have read some research that shows that there is a negative effect or no effect.
Okay, so I was actually referring to up to 2012. From 2012, this year, 2013, it does get a little bit confusing.
Right.
Now, essentially, just looking at the negative studies is actually quite informative, because they teach us something about why it might be difficult for depressed patients to benefit from exercise, as much as questioning whether exercise works per se. So the first negative study that I can recall, the big negative study cited in the literature, was from Jasper Kroch from Denmark, and that group looked at the so-called demo studies, which compared different types of exercise. So, for example, aerobic exercise with strength exercises, or aerobic exercises with, in the Demo 2 study, stretching. And those 2 studies are cited to be negative in the literature, the first one from 2009 and the second one from 2012. So that was perhaps a red flag to say, well, is it really helping, or what's going on in those 2 studies? Although if there were 30 studies and 2 outliers, you might say, well, it's still fairly clear, depression is helped by exercise. But then in 2011, there was a study by Trivedi in the US, actually Duke University, and that study had quite a large recruitment as well, so the sample size was fairly good, and that's sometimes reported as a negative study, but they actually really compared high intensity exercise and low intensity exercise without a comparator arm, so without no exercise, and both groups did benefit, but only slightly. So at 3 months, 30% had achieved remission from depression with exercise on its own in the high intensity group, and 15% had achieved remission in the low intensity group. There's something special about that study, the so-called TREAD US study, which is that they looked at a treatment-resistant group who might benefit from exercise or medication, but it's not clear. They'd already failed effectively on a medication. So that's a kind of precious group that we need to be helping in depression studies. Those people who'd been tried on initial antidepressant but hadn't done well, and then clinicians weren't sure what to do. They went into this study and they achieved that 30% or 15% remission at about 3 months, which really isn't that bad. So I don't actually count that as a negative study. The thing about the Koch studies, the Koch studies actually had a low recruitment number. They aimed for 300 patients, but 100 initially refused or declined to be involved in the exercise program. So that it immediately tells you that there's a problem with the power of that study, how likely it would be to show a real effect. But it also tells you that there's a problem recruiting patients to quite intense regimes, and the actual final number that was participating in exercise was less than 100 in those studies. However, there's a fourth negative study, and that's TREAD UK. TREAD UK came out of Bristol. The first author who published in the BMJ was Chaldan. Also involved in that author was Glyn Lewis from Bristol. Now, TREAD UK is important because it is the largest study in the literature. They actually recruited 360 patients, and they recruited those patients from primary care, and 180 were randomized to an exercise arm, and 180 were randomized to a no exercise arm. And the study is quite controversial in the literature because it's definitely reported as negative. There was no benefit from being in the exercise arm for current depression. However, that study is slightly more complex than it first appears, because what they really did is they randomized people to an offer of exercise, which is actually a very important question. If you're in primary care as a GP and you have a patient who's depressed, generally what we do is recommend an exercise program or offer advice regarding exercise. It's not actually clear whether we go further and really monitor and help to make sure the uptake of the exercise is good. So we usually offer as an initial first step. So the study by Chalder looked at the offer of exercise, and what they found is that the offer of exercise, which was backed up, I have to say, by the additional 3 potential face-to-face sessions, checkups, and up to 10 telephone calls. So it wasn't purely the offer in the clinic. There was some kind of attempt at follow-up. But nevertheless, even with that package, only 52% of those in the trial actually took up exercise to the minimally adequate amount in the treatment arm. And as it happens, those in the control arm, who were not really meant to have exercise, were exercising anyway to a reasonable extent. In fact, 43% at 4 months into the trial in the control arm were exercising versus that 52. So what that meant is in the study you've got this very, very narrow differential between the active and the comparator arm. And perhaps if you look at it that way, it's not that surprising that there wasn't really a big difference at the end of the study, either at 4, 8 or 12 months. So those altogether are 4 apparently negative studies that have raised this question in a lot of people's minds. Does exercise really work after all? But there's a large number of positive studies, and those 4 negative studies do have limitations that I've outlined there.
And so what factors actually influence whether exercise is going to be beneficial?
Well, that's a good question, and you have to really go into the studies and unpick that a little bit. Initially, it was suggested that exercise is only suitable for those with, let's say, mild to moderate depression. And that might be an effect of participation. If you have severe depression, it's hard to take up advice to exercise. Another factor might be gender. For example, males may find it slightly easier to take up treatment advice to exercise. But probably looking at the types of exercise is important as well. So for example, in those Koch studies, they looked at comparator between exercise aerobically, stretching, and also strength exercises. And really the bottom line there is they were all quite effective. So at face value, it's probably the case that participation in non-aerobic exercise is likely to help depression as well as aerobic exercise. However, other studies, a US study from Blumenthal and Hoffman, 2007, looked at whether the number of minutes involved in the exercise program was influential. And actually it was influential to a significant extent. So the jury's out on what predictors are really, really influential. But we do probably have a lesson that participation is important, and we don't know whether type of exercise is particularly important.
And has exercise actually been shown to help over the longer term with depression, so in keeping someone well?
Yeah, that is really important. So if you are already well from depression and perhaps considering how to stay well, does exercise actually prevent a future episode? This is what the clinicians would call a maintenance treatment, a relapse prevention strategy. And the only study to look at that I know of is the same group that I just mentioned, the Blumenthal one. They looked in this so-called SMILE study, the SMILE study, whether participation in exercise, this was published in 2000, and Bavayek was the first author. And what that study showed in 2000 was something very interesting, actually, that compared with a drug, I think it was sertraline, antidepressant, SSRI, head-to-head in a relapse prevention strategy, exercise on its own with no drug was more effective in preventing a future episode when followed up for, I think it was 6 months, 6-month follow-up after the primary intervention finished. It was more effective than the drug alone, and the differential was really significant. In the drug arm, over 6 months, in people who'd already responded to depression, 40% relapsed. But in the exercise arm, only 5% relapsed. However, the confusing thing in that study, when I looked at that again recently, was that in those that received both, because you could have combined exercise and drug, which in nearly all studies is the gold standard to receive 2 options in 2 modalities rather than 1. In those studies, in that one study where people had received both, it was actually an intermediate effect. It wasn't a superior effect to exercise alone. So I think there might be an issue with the fidelity of that study. In other words, the sample and what happened, but it's still intriguing, and it definitely requires a replication, that study.
So if we actually think about people who are depressed, based on the current research, what should they actually do?
Overall, I would say the evidence is still in favour of exercise improving depression. The evidence is clear where people are able to participate in that programme. So really the advice is to participate in exercise to a degree that fulfills the minimum national standard, which is exercising roughly half an hour, 5 times a week, which is quite a lot. Let's take a person who's not able to achieve that. It's still worthwhile exercising to a lesser extent. And I'll just cite one study here, which is from a Taiwanese group, just published in Lancet, called, the first author's Wen. And that study showed in a huge sample, I think it was nearly 500,000 Taiwanese general population, that the number of minutes, even at a very low level, improved mortality in the population. It didn't require a certain minimum threshold, the 150 minutes, which I can see is quite a big target. Even 15 minutes of exercise a day improved the mortality of those participating in 15 minutes compared to the general population by 14%. In fact, at that low level of exercise, a take-home message from that paper is that each minute spent exercising a day was the equivalent to the percentage in mortality saved compared to the general population. So 1 minute a day actually saved 1% of mortality for those exercising 1 minute a day. The point I'm making there is even a small amount can be beneficial for the health of the population. You don't necessarily have to aspire to a very high target. However, if you are able to achieve moderate to intense exercise for a reasonable period of time, it will be even more beneficial. And that's been shown in depression in that Blumenthal study, the SMILE 1, SMILE 2 study, which actually showed a dose-response relationship between the amount of time in aerobic exercise and the likelihood of improvement. But it wasn't. It was subject to a plateau. In other words, if you exercise more than, let's say, 150 minutes, you didn't get more than 90% chance of remission of depression. That 10%, there was 10% in that study that didn't respond to exercise no matter how many minutes they did. So exercise isn't the answer to everyone's depression. It can't solve every depression, just the same way that no strategy can solve every depression on its own.
So we were talking about how any amount of exercise is beneficial from the point of view of mortality, but from the point of view just of looking at depression, if I was a depressed patient coming to you, what would be the minimum that you would recommend?
I wouldn't say that there had to be a minimum. I would say any amount that you can do is likely to be beneficial. In fact, my job there would be to help the patient take up exercise to an adequate degree. What we're talking about here is the danger of setting targets which are too high, particularly in a mental health setting, and having patients who have relatively little resource to actually have easy access to exercise, hear that you're advising it but not be able to achieve it. It's akin, if you like, to me recommending a drug strategy which is associated with lots of side effects. If I recommend a drug strategy which has lots of side effects, it's unrealistic for me to expect the patient to stay on that drug a long period of time. But because I'm not experiencing them, it's tempting for me to just prescribe it and expect the patient to live with those side effects, which I don't think is very fair. So equally, although I know that being involved in 150 minutes or more at a moderate or ideally intense level is the ideal, I also recognize that not everybody can achieve that. So I would try to sell the idea to the patient that some degree of participation in exercise is going to enhance their well-being. And if they don't want to do aerobic exercise, I'll accept that, because the literature actually does show that different types of exercise are probably therapeutic. So if they want to do more like calisthenics, yoga, even things that are going into kind of complementary treatments, I think that's fine. It's not the ideal. The ideal is intense aerobic exercise, but I recognize that not everybody can do that. And at the end of the day, everybody's got to start somewhere. One of the aims here is to start with something and then gradually build up. It's like literally a marathon runner who's had time out with a fracture or a strain. They're not going to begin at running the marathon having had 6 months out. They're going to begin at a lower level and build up. And that's exactly the same for anybody not used to exercise. You've got to build up from a lower level. And you feel that there's a goal, and you've got to feel supported in that, and you've got to feel that something's being achieved.
And do you have any other recommendations for clinicians if they're faced with a patient that is really struggling to either embark on a program or to keep it up?
I guess the key advice would be that don't stop with simple advice. It's a bit like the question about why smoking advice in the GP surgery is not always effective. And it's often because we only give the advice. It's only a subset who receive specific practical follow-up recommendations and then follow through to check up. So the most simple thing is to follow through with the patient, essentially see them again, and review, are they meeting the targets? Are the targets realistic? They can do an exercise diary, an activity diary, look at their whole lifestyle, something preventing the ability to exercise, and then look at access. Are you able to prescribe something literally? For example, in the UK, we often have this new strategy here called the community gym program, where GPs in some centres, and I know it's not available everywhere, can prescribe access to a gym which actually provides the patient with free access to a valuable resource local to them. So that's an intermediate step. Let's imagine then that the patient's still not able to participate. What can you do for somebody who's really struggling and say, it doesn't matter what you say or what you offer, I can't do it through my own motivation. Now, one new thing, it's not new in medicine, but it's maybe new to mental health, is looking at the idea of peer support. And a peer support model is really trying to create a group or a setting where patients can come and do some exercises together. And that requires some organisation, and there's a cost to it. But some centres are doing that and doing that successfully. And that's definitely worth considering, because the power of group support can help a lot of things, including participation in exercise. But in addition to that, I think there'll be new programs coming online where we mentor people. We basically give them a peer buddy or mentor who is able to go and do some activity with that person one-to-one. So if they don't like the idea of group support in the community or the hospital, we might be able to ally them with somebody who can outreach to them in the community, but actually take them and help them with the exercise regime, almost like a personal trainer, but not at that high level, at a basic level, and coming from a perspective they're coming from. Starting at a basic level, not making any assumptions about what people know and what they don't know, and giving them encouragement and demonstration from their previous experience about what helps and what doesn't help.
I think there are some really interesting ideas there. So, in summary, does exercise help with depression?
In my opinion, based on the current evidence, if a patient is able to participate in a program and participates to a degree that they personally find fulfilling in terms of activity, then I believe that there's evidence to show that it helps mood to a significant extent in terms of helping alleviate their current depression. It's not a panacea. It doesn't necessarily work where all other things are against you. It is dependent, in my opinion, on participating in that activity. And it is a little bit dependent on the amount of exercise done and what is actually chosen, or I've said that is a grey area. And probably from the literature, although this is really reaching here because there's only one study, it may help as a relapse prevention strategy. So 1, in terms of getting well, and 2, in terms of staying well. So I would definitely encourage people watching this, if they're either feeling depressed but wanting a strategy which is simple, or they've been depressed and thinking about how to prevent future episodes, to strongly consider exercise and physical activity in general as a form of positive treatment that they can do themselves that will enhance their quality of life.
Thank you, Dr. Mitchell.